didn't think I would be stuck to the podium, but I don't have a walk mic, I don't have a clicker, so we're moving on. We got this. There's arrows here, right? Yep. Perfect. As long as I got arrows. Oh, you know what? I think I found it. Let's just test this baby out. Yep, okay. I got that part. I am Dr. Nancy Taylor. I am a pharmacist. I am a board-certified patient advocate, and I am a certified senior advisor. I am also a 30-year amateur golfer. I have one of the best toe wedges you will ever see. Yep, you pay my green fees, and I will show you what these puppies can do. I want to thank you for sticking it out. I know this is the last. Everybody wants to get out and go do something, and everybody's tired and cold. So thank you so much for sticking out with me. How many of you, though, plan to go to the pool party this evening? Okay, a good fair number of you. Wasn't it awfully nice that Caesars gave us all white bed sheets to wear? I'm waiting to see what you got for your little emblem that's going to hold that puppy up there, maybe tie it around your neck. But before we really talk about transitioning into I could care less at the pool party, I want to bring you back to talking about transitioning in care. I want to give you some knowledge and some tips when it comes to what you can work with your clients and what that safe transition can look like. How many of you knew that miscommunication and medication errors during transitions of care are among the top reasons that patients are rehospitalized within 30 days? Fantastic. I'm glad that you know that. How many of you have ever seen a solution to it? Nope, nobody raising your hands? Okay. All right, well, we're going to talk a little bit about that. First off, I have to tell you, last fall, I got to take my first ambulance ride. I was not expecting it, couldn't figure out why I felt so bad, and told my husband, you call the ambulance. And so they came to my home and carried me down the stairs, loaded me up, put me in the ambulance, which I have to tell you is one of the bumpiest, hardest rides I think I have ever had, and that includes amusement parks. And so took me to the emergency room. During this time, the EMS is asking me all of my questions. They are going through my list of medications. I'm trying to explain everything to them. I'm not even sure if they even understood some of the generic names that I've been throwing out. And okay, we get to the ER. And then they ask me again, right? That's right. So EMS is telling them what I'm taking, right? Because that's their job. Hey, we got this person and this is what's going on. They're on this and this and this. And then the nurses are coming in and they're asking me and I'm telling them what my med list is and, you know, talking through that. And then what happens? Doctor comes in. He's going to ask me the same questions, right? Okay, so far I've been asked the same questions. So I'm telling him what this is. The nurses are also telling him what this is. And now I'm really going to date myself. How many of you played that game telephone when you were little and you passed it on and then passed it on, passed it on, and by the time it got to the last person and they had to tell you what the original message was? Totally different, right? Yeah. Well, we have one more here because not only as I am in the ER, they transfer me up to ICU. And so now I'm being not asked again. I was not asked again when I went up to ICU. They just assumed that everything that they were told was correct. I will tell you, how many transitions did I just do? I went from home to the ER up to ICU. I had to correct them 3 times. Because they got my medications wrong. So can you imagine your clients who are not pharmacists like me, who are on top of it, can remember all of this and have that. Can you imagine all of those questions bombarded at your client and trying to keep it right, trying to keep it straight? So you can see how quickly and easily we have medication errors in transitions of care. And that is one reason why I preach about this. There is very good reason to have the conversations on transitions of care with your clients. Now, we as practitioners, we as advocates know a lot of this information. It is our responsibility to make sure that our clients know this, and we need to make sure that they understand certain definitions. You have already heard different conversations throughout these last couple of days on health literacy, making sure that everybody understands what things mean. Well, tell them, hey, this is called med speak, okay? This is where the provider is talking above the understanding. And this is where we are really good at being that translator. We know what the med speak is. We know what our clients want to understand, and the look on their face is, Make sure that your clients understand and the providers understand. Bring that together. Another definition that your clients need to understand is generic substitution, because it happens without even talking about it. So that is switching between the generics, not only of brand generic, but generic to generic. All right, all of those subclasses. Formulary. Boy, that's a big word, isn't it? How many of you talk to your clients and drop that formulary word? They're like, okay, But if you were to say, you know that list of medications that your insurance is going to pay for? Again, there's that med speak. We had these big words. Make sure they understand what the terminology is, because they're going to hear it from so many different people. So make sure that they understand that when somebody says the word formulary, they went, oh, yeah, that's that list. Readmission rate. And this is important because we just said this. We all raised our hands. Yeah, we know miscommunication and medication errors make that readmission rate go up. All right? And then the other thing is sliding scale. Clients do not understand what sliding scale is. We do. It's very important that you talk to your diabetic clients and they understand what that means. Because when a diabetic client gets transferred, so they make the transition into the hospital, they have a whole different protocol. And it can be very scary to a client if you don't take the time to have the conversation about the changes that are going to happen just because they're diabetic. So let's talk about what those dangers are in the transition. Wrong medications, right? We know there's a whole lot of look-alike, sound-alike out there. You know, I even did it the other day. I was talking with somebody, and I wanted to say, I used doxalamine instead of dicloxacillin. Completely two different drugs, right? And if you look on bottles and things, they're trying really hard to, some it's going to be in small print, then large print, some, so it's almost it's hard to determine. So you need to make sure that you're looking and you're understanding, and sometimes it really helps to say it out loud. Because when I did it, I said it out loud and I went, whoa, that's not what I want. Because it wasn't what I was used to hearing. We also have missing medications. They didn't get entered into the orders. When you've got somebody who's got a laundry list of 23 medications, it can be very easy to have one of those missed, and it just didn't even get put in the order. Then what about our order transfers? I was just to assume that whatever the emergency department put in, ICU got. Nobody in ICU asked me. Okay, there could have been something happened in transition. We know we can't rely on technology all of the time, So it would have been nice if somebody would have checked with me. Maybe there was a problem transmitting from ED to ICU. And then there's also the dosing errors, okay? Not giving the meds as prescribed. Now, there are very few hospital systems out there and even SNFs, long-term cares, that are not computerized. Okay? However, you get into rural America, they're still writing things. They're still taking orders. The doctor that comes in overnight may be like, yeah, okay, just do this, and writes the order. And whether it gets scanned in somewhere or it gets handed to somebody else, you still have to make sure that you understand what that order is what's correct that's being put in. And that's not always happening. It also can be an easy typo, and it's an easy to not necessarily understand. You're going to put them in, maybe your fingers fly faster than your brain, and you were supposed to put in QD for once daily, and you typed in QID, and now they're getting a drug 4 times a day instead of once a day. So there are errors that are still happening. And these are the biggest things that happen during a transition of care that can lead to that rehospitalization. So where are these breakdowns? Okay. We went through a whole huge thing on discharging alone. And it happened in COVID, but I don't know if you have noticed, but even after COVID, they're sticking to some of those rules, and they're letting the patient be discharged alone, or they're letting the patient be transferred alone. I'm sorry that my slide is out of whack. It was not when I started. So even after COVID, many caregivers are not allowed to transport with their loved ones. All right, we got that? Okay. And that is so true. Used to be able to all the time, not now. That health literacy, there's the breakdown. We talked about med speak versus that patient level. And does anybody know at what level, what grade level that patient speak should be? Give me some shout outs. 6th, 3rd, yeah. Okay, it is now moving down to that 3rd grade level. I kid you not. I'm sorry, I don't have treats for you. But you do get to be the first ones to buy me drinks. Raise your hands first, yep. And so it's very important when you have somebody that is, all they do is speak in medical terms all of the time, to have to then figure out what's the word I should use that this patient's going to understand. And that is where we as advocates can be constantly educating our clients of what these words mean, and really basically, telling them what that said. Discharging pharmacy reviews. Did you know that this was actually a requirement at discharge? How many of you have had the pharmacist come in at discharge and talk to your client? Right? Okay, so there can be that lack of that final medication review by facility pharmacy department. How many times have you been with somebody and they've been discharged and the pharmacy didn't even know it? Right. That happens all of the time. So there is a big breakdown right there. And then we talked about that generic substitution. Definitely understanding where and why substitutions occur, what the necessary part of that is. And then there's also the questions to ask. And patients and caregivers just don't know. They don't know what to ask. And if we have not talked with them about that, then that's our fault. Something happens, that's our fault because we have not educated them well enough. Take a look at this. They didn't even have all my dad's medications when he admitted to rehab. We were told we can't use his home meds. Then we were asked to provide them in the short term. This happens all the time. I was working with Lisa and her father, and they were told, again, and this is one thing that happened too, he was transferred from the hospital to the rehab, no caregiver with him, not allowed, okay? So the other person had to come in, the caregiver had to meet there. So, no, we can't use your medications. It's a Friday afternoon. What pharmacy that is associated with a skilled nursing facility, rehabilitation, can get you your meds on a Friday afternoon? None. So they came back to the family and said, oh, we're not going to be able to have some of these medications until Monday. Can you just did you bring those? Can we have those so that make sure your dad gets his medication? This is a huge breakdown right here. And it was difficult, and it was a good thing that I was there, because I became the bully. And I know you cannot imagine that I would speak up and be a bully for anybody. Yeah, but I get paid to be the bully, and I'm okay with that. So this really is a breakdown. This broke down from the hospital through that transition into rehabilitation for this family. So let's talk about the prevention of it. We can prevent this. We can do the best we can on that. And I'm going to talk about just 3 areas. We know that they can go up and down within the systems, like I did. But let's just talk going from home into rehab and back, all right? So I talk about making that medication list, okay? And it's not just I'm on Eliquis. I take lisinopril. No, this needs to be as complete as possible. So it is the name, the strength, the dosing times, and this is included in the over-the-counters too, because a lot of people don't believe that those pertain to their medication regimen at all. And they do, and that's another presentation, and we can talk about that later. Take a picture of your medication list. It's great to have a paper medication list, but also have it on the phone, because we have our phones with us all of the time. Or the adult children are not going to be searching through the overnight bag for a list. They want to just pull it up on the phone. So make sure you take that picture. And then verify the list with the hospital input orders. Okay, you have your home list. They're putting it in. Again, we go back to that one picture where it was missing on the input orders. This is a way that you can prevent that, and you can ask them, may I see the medication list that you had just put in? And you compare it right there, okay? And make sure that's there. If there's any question, then you ask, all right? And we're going to get to that. If they're going from hospital to rehabilitation, get a copy of the discharge orders, because we all know the original discharge orders go with the patient. And the patient is in the ambulance headed to rehab. You're the caregiver. And yeah, you may have looked at it when the discharge nurse came in and said, okay, here's everything he's going to be on. These are what he wants me to do. And they're going to go, and so that's the last you saw of it. And then the rehab center, depending on the time that you get in there, they may not even be able to give you a copy of them. So you make sure you always get a copy. And you just ask, may I have a copy of that before we leave? Take the home meds with you to the rehabilitation facility, okay? The better to have them with you and not need them than for them to turn around like they did to Lisa and say, can we use your dad's home meds? All right? Because if you've already left, then they're not getting that med at all. And now we've got a breakdown. Again, now you're going to verify that list. You're going to see a recurring theme here in verifying that list. So what do you have? You have your list from home, right? You now have the list from discharge, right? They're now in rehab. They've entered all of that information in. They've created their own list. You now have 3 lists to compare to make sure that things are moving consistently and steadily all the way across. You have every right to all of those lists. And as the caregiver and as the advocate, It's your responsibility to make sure that those are all correct. And if they're not, speak up. Now let's go home. Okay, rehab's been successful. We're going to go home. Did you know that you get to take all your meds with you? How many leave rehab without taking the meds that they've had in rehab for maybe up to 30 days? They charge you at the beginning of the month, and then maybe you're there for a week. Your blister packs of meds are sitting there. You've paid for them. Take them home. Okay? Also, know the generic substitutions and to avoid the duplicates. And we see this, and this is one of the things where I think it's very important that you make sure you talk about generic substitution, because you could end up with duplicates. And this all comes down to formularies, and we're going to talk about that. Then you have the list, you have all these meds. You're then going to take your most recent medication list to the follow-up appointment with the doctor. Say, I have been through here to here to here. Now I'm back to you with my follow-up. This is my most recent list. Is this what you want me on? Is this where I'm supposed to be? And through all of that verification, hopefully we can not have as much breakdown as possible and your client not be rehospitalized because something's been dropped. Okay, let's prepare for it. How are we going to prepare? It is quieter than a tomb in here, isn't it? Okay, at least somebody's teeth chatter because it's cold. Give us a little background noise. All right, so let's avoid a breakdown during transition. Know what to expect at each transition of care. That is really important. So as you're the advocate, working with your client, and you know that maybe something's going to happen, they're going to do an elective surgery or something, or even if you've missed that very first one and they bring you in at the hospital, talk with them about what to expect at each transition that's going to have. Use the transition of care checklist. Nancy, where do I get a transition of care checklist? It is on my website, but you are also going to get a QR code. And I have made that extremely 3rd to 6th grade level. So you can share that with your clients. And then prepare before you go. We have, and the checklist takes you through it, but we did talk about make your list, take your pictures, talk about what these things are, go over definitions. Then make sure that your patients know they have rights, okay? We know that great hygiene really can reduce the possibility of infections. Okay, so that's a good place to start. Create that demeanor with your nurses and everything else. Start with that. Ask to see the medication list before, during, and at discharge of your stay. Even if they just turn the computer monitor, pull out the list, pull up your phone, compare, all right? If anything looks different, ask about it, all right? And here's a really good reason, and I want to talk just a really quick minute about that formulary. My friend Tammy, okay? Let's say that Tammy takes enalapril for blood pressure at home, all right? Tammy's going in for an elective surgery. So Tammy goes in, she's got her medication list, she's handed it off and everything, and they look at that and they say, oh, we don't use enalapril here in the hospital. It's not on our formulary. We use lisinopril. It's in the same family. It'll be just fine. So during Tammy's entire hospital stay, she's going to be on lisinopril for her blood pressure instead of enalapril. Okay, maybe Tammy needs to go to rehab after that because she's got to really get that working going, knee, hip, whatever it is. So then she goes over to there. She's being discharged on lisinopril because she's being discharged before the hospital pharmacy got to review it and change her back to her home med of enalapril. So she's still not getting her home med that the doctor wanted, so she's on lisinopril. She goes to the rehab. And they're like, oh, Yeah, we do lisinopril. That's fine. They keep her on lisinopril. Okay? She gets done with rehab. She's discharged on lisinopril. So now Tammy has enalapril at home. She has lisinopril from the rehab center. Maybe Tammy doesn't know that she isn't. She's like, well, I was taking this, and then they added this. And then maybe Tammy takes both because she doesn't know they're in that same family of medications. Okay, so now we have a problem, and we probably have a rehospitalization coming up. All right, so it's very important that when you talk that generic substitution with your clients, that they understand these substitutions come along, and you have that list, and you're able to follow with that list. I also highly recommend that you ask that each pill, what it is, when they bring it to you, you ask to see it, you ask them to tell you what it is and what it's for. And don't let them get away with, this is your pain pill. This is your blood pressure pill. Okay, if Tammy's blood pressure pill was pink, that she was used to seeing, and it's enalapril, and now she's in the hospital and somebody comes to her and says, oh, Tammy, here is your blood pressure pill, and it's white. And Tammy says, that's not my pill. I don't take that. Well, yes, you do. That could have been a whole conversation prevented just by discussing generic substitution. Okay? Let's talk about those who actually are solo agers. Who's helping them? All right? And I'm glad you're helping them because they don't have necessarily caregivers or family members. So how does it look different than if a caregiver was there? Think teams. Always think teams when it comes to solo agers, okay? They have two teams. They have a healthcare team and they have a home team. And as advocates, you can help them put these teams together, all right? So who's their designated medical power of attorney? Who's going to be at their bedside? Is it going to be you? Is it going to be their friends? Is it going to be the pastor? Transportation. All right, they're going in for an elective knee surgery. They're walking in, but they probably aren't driving home. So who's going to be doing that? Are you going to have to set up specialized transportation? Is a friend going to do it? Are you going to hire a car service? What's that going to look like? And who's going to help them go through that transition of care checklist? Okay? But they're solo agers, so you've got to work with them on a home team also. Okay? We talk about treating and caring for the whole patient, the whole client. Well, here's how you can help that with those solo agers. Who's going to take care of their meals? Maybe they have to have their leg elevated for so long. Who's going to take care of the transportation? How is that going to be to get to their doctor's appointments? All right. What about who's going to take care of their dog while they're in the hospital and then they go to rehab? Their pets are their lives. Solo agers, those are their babies. And so who's going to take care of that? That is going to be a huge worry for them while they're going through a transition of care. And we certainly don't need their anxiety added to their physical inabilities. So take a think about that. And what about errands? Who's going to go pick up their prescriptions? You can have groceries delivered. Great, that's awesome. Who's going to, have to take their bills to wherever, or who's going to meet with that? So help them create this home team. Be part of their healthcare team, but go that extra mile and help them create this home team. Okay? I want to get down that we try to talk with our clients about being the best advocate they can be, okay? But going through a transition of care can be extremely scary for people, all right? But it doesn't have to be. It doesn't have to be at all. We are there for them, and we all know that the more education that happens, the more in control and confident we are, and we need to provide that to our clients. So you can help avoid the misunderstandings, you can help with the fear, and it will save all of that exhaustion and stress. You do have the information, and you can empower all of your clients to be their own best advocates. And here's a good way how. Hit your QR code. This is downloading that transitions of care checklist. Make sure your clients have this. I am quite all right with you sharing this to whoever needs it, because this is going to help in the prevention of miscommunication and medical errors, and it's going to help reduce that rehospitalization rate. And if you don't want to catch it right here with your QR code, you can always go to my website. It is on there. You can put your name in, and you can open up that transition of care checklist. All right, I did my best to get you some time before the pool party. Thank you very much for going through this with me. I will now open it up to Q&A. And if you want to speak with me after this, that's fine too. So do we have any questions? We're a small group. You can just shout them out. Yes. Oh, you're here. Okay.
Is there another microphone?
Nope.
Okay.
Go ahead, Nancy.
Do hospitals publish their formularies anywhere?
I don't know that's necessarily published, but you can ask for one.
So do you just call the pharmacy?
You can actually get it through admitting. Absolutely. Because the pharmacy isn't going to know the formulary. They don't do the bookwork like that. So you need to talk with administration and ask for that. And here's a good thing too that you can do with your clients if you know it's an elective surgery. You've got the list at home. You can get the formulary of where they're having the procedure done and compare already. And so that you're educated before you're even going in. Yes?
So in the scenario where you're talking about rehab, and the drug that was generic drug was ordered, is there some way that we as advocates can try to create that scenario where the client might be taking the same medication twice? What can we do? Is there any communication that could be done with the rehab group to avoid that?
Absolutely. Okay, so her question was, in that example that we did where I said that could possibly be on 2 of the same class of medications, you're asking how could we prepare that that not happen at all, correct?
Especially when you're not as used to the drug
Right.
as you might be,
Okay.
that's not versed with medication.
One of the really good ways is knowing what the drugs are for. And when I say that, your client may say, I am on, when you fill out that medication list, their drug is for blood pressure, all right? How many drugs are they on for blood pressure? If they're on 1 drug for blood pressure, and now you see 2, that's a red flag, okay? And the other thing is too, you or your client can always ask to speak with whatever facility pharmacist there is. There is a consulting pharmacist for every skilled nursing facility, every long-term care facility, rehab. There is the hospital pharmacist. If you and your patient are headed to discharge and you have not spoken with a member of pharmacy, that's an unsafe discharge. Okay? You ask, I would like to speak with a member of pharmacy. Can you send someone up to this room? And go over the lists with the actual staff pharmacist. Same thing if going rehab to home. Like, I would like to speak with the consulting pharmacist before we go home. And you have every right to ask that and go over those lists and make sure. Okay, any other questions? Yes?
What happens in a situation when you have a discharge, and I've had situations where the client has the med list, but then if the hospital says, pick up your meds at the pharmacy after you've been discharged, then we find that the pharmacy list is different than the hospital list that they would get. What do you do in those situations like that? What's the most effective way to help?
Okay, his question was, you have a discharge. At discharge, they say, we're sending all of your medications to the pharmacy. And so then you go to the pharmacy, and those are not the same kind of medications that you were expecting. This is where you utilize that pharmacist at that, where you're picking up those medications. You take your discharge orders into the pharmacy. I've done this many times working with lots of caregivers that are coming in. And they say, these are the discharge orders, and we look at the meds. And then they're able to even show me the med list that they have that's at home. If it's their regular pharmacy, they see what they're regularly on. And then they see what those discharge orders are. Utilize that pharmacist and say, this isn't making sense to me. Why would it be this way? Or why, I was not told that this was going to be a change. Can you place a phone call? Why would I have this? And so that is one more step before it gets out the door and it could be wrong. Does that answer your question? Okay. Any other questions? Yes.
I have an elderly sister who lives in another state, and I'm the only healthcare person in the family. So I am helping to monitor her medications. However, she gets her medications from a mail-order pharmacy. So how can I double check with the mail-order pharmacy to make sure her list of medications is correct?
Okay.
Can I do that, or do I have to contact the physicians who wrote the medications?
Okay, so her question is, she takes care of a family member in another state who gets their medications from mail order, and she would like to know how that she can be on top of that medication list for her loved one in getting those medications from mail order. My first question to you is, are you her medical power of attorney?
No, her daughter is.
Okay.
And I'm working with my niece because she doesn't understand the medical side.
Okay, what it's going to come down to is there is going to be a form from that pharmacy that your relative will have to sign that says, I give permission. It's a release of personal health information, and that mail order pharmacy will have their own. And so once that is signed and it goes to that mail order pharmacy, then they have permission to discuss that with you, and you can contact them and visit with them over the phone to get that information. But you do have to have that form first. Yes? So she's making the comment that it's not standard practice for pharmacists to come up to the rooms and go over medication lists. And I will tell you, in most places, it may not. But the patient's rights and the caregiver's rights have that right to talk to that pharmacist. Okay? The administration cannot say, I'm sorry, you can't talk to a pharmacist. And if they do say, I'm sorry, you can't talk to a pharmacist, you say, okay, that's fine. Let me talk to your risk management. Okay? Because you have, as a patient, you have every right for that. Yeah. It could easily be an unsafe discharge. If you are concerned that those medications are not right, that can be an unsafe discharge, yes. Okay, any other questions? Well, thank you so much for being here. I really appreciate this. I'm still around through tomorrow, so if anybody has questions, you can flag me down. I'm easy to find. So enjoy the pool party tonight. Get to be outside where it's warm. Thank you all very much.